Corina, we welcome you and please start off by telling us what is social organization of care and how it is different from what Rosa was talking about, the care economy. Please tell us and also sort of touch on the highlights from the study that you've been doing.
Thank you, Ni. Hello, everyone. Thanks all of you to be here today. I'm very happy to be part of this conversation. And as Rosa and Ni have already said, I will present the highlights from work that is a work in progress that we are doing as a collaboration with PSI to analyze the current shape of the social organization of care, to learn from some good practices, and to learn how or to think about how we can move towards a rebuilding of the social organization of care. So the study will have some concrete proposals to push for this. It's a global study, and this is also a strong of the study. We will look further in the 8 countries that Rosa already mentioned. And in this presentation, I will highlight 3 aspects of the study, the conceptual framework, and there I will address Ni's question about the care economy and the social organization of care, the main common and differentiated features that we have seen so far in the country cases, and some good practices that we already are foreseeing that can be a window of opportunity. So in terms of the conceptual framework, we move from the idea of care economy to the idea of social organization of care. The idea of care economy is focused on the recognition of the systemic economic role of care work, which is mostly unpaid and undervalued and underpaid care work. And this idea of care economy try to assess the economic relevance of the care sector, understanding it as an economic sector that can create employment, that can distribute income, and that can push for the economy recovery. This is very much said these days. And of course, this idea is very relevant, and the concept of care economy has been very useful to bring the issue to the public domain, to push for public discussion. But now it's also challenged by a view that push for greater commodification and even financiarization of care services. And this is, as Rosa already mentioned, in line with the increasing influence of the private sector in social provisioning. So to face this, instead we propose to move to the notion of social organization of care that focuses mainly on the interaction between the households and the unpaid care work that is done mostly by women. So the interaction between the households, the state, the market, and the community in terms of community-based care arrangements. And this notion of social organization of cares brings light to the imbalances of responsibilities between these different care actors, between the state, the households, the market, and the community. And by looking at this approach allows us to identify the key dimension of inequalities, because we really believe that the way that care is socially organized these days is a very key note of reproduction of inequalities, gender inequalities, but also socioeconomic inequalities. So for us, it is very important to rebuild the social organization of care if we want to push for a more fair and just world. And our framework is also based, as Rosa already mentioned, in the idea of the right to care, the care as a human right. Because where there is a right, then there is a chance to reclaim the state. If we understand care as a right, as a human right, we can reclaim the state to fulfill this right. And here it appears the key role of the state and the public provisioning of care. So as I said, this is a work in progress, but I can share with you what we have seen so far. The first highlight is that as we already knew, the social organization of care is currently unfair, but also this unfair of the social organization of care looks different in countries in the north and in countries in the south, and even between countries in the same region. But there are some common features in the social organization of care in the countries we are looking at. The first common one is the sexual division of paid and unpaid care work. It's not only unpaid care work that is feminized, also paid care work is feminized, and the sexual division of care work is still very, very grounded. The other common feature is the burden of unpaid care work on women. The intensity of this burden is different between countries, but everywhere women are still facing the greatest part of unpaid care work. Feminization of paid care work is also common in all countries. And also the issue that many paid care workers are migrants. And this is true in countries in the north, but also in countries in the south. It is the case of Argentina, it is the case of South Africa, countries from the global south, where still many care workers are also migrants. And the last one of these common features is that most of paid care work is precarious work. And this is true not only for domestic workers that we know is a very precarious activity everywhere, but also for health workers. And this, it is true even in this context of pandemic. Some differences between countries. Public provisioning of care seems to be more relevant in countries in the north, with a stronger welfare system, with a stronger history of public provision. But however, there is a trend, even in these countries, towards commodification, even commodifying the public provision through contracting private actors to concrete the public provision. Public provisioning in countries in the south is uneven, and it very much depends on the path dependency of the welfare state, and how deep the structural adjustment in the past have challenged the social provisioning. And in countries in the south, family and community-based care arrangements are really relevant and key. This is true for countries in Africa, also in the case of some spaces in Argentina. Also, maternity paid leaves, or more generally care leaves, are different among countries, and this has very much to do with the different shape of the labor markets. And the last issue I could highlight in this sense is that the private provisioning is increasingly relevant everywhere. Although access is very uneven by socioeconomic status, especially in the global south, the quality of private provisioning is also very uneven. It's not true that private provision is always of a better quality, and this is also true in the health sector, where in many countries public provisioning of healthcare is of a really good quality. And the difference between the countries we are looking at in the north and in the south in this regard is that regulation of the private provisioning is stronger in the north and it's very weak in the south. As I said, community-based care arrangements are very relevant in countries in Africa, also in India, and there is also a role of NGOs as care provisioning in these countries. And the last issue is working condition of paid care workers that is also very uneven between countries, where we see a tendency of better conditions in the north associated with the higher rate of professional care workers. But in this stage of the work, that it is a work in progress, we already are seeing some windows of opportunity to push for a change of this unfair social organization. And I have one example in the north and one in the south. One in the north is the case of Australia, that has this Royal Commission into Aged Care Quality and Safety, which has done a very deep analysis of the shape of elder people care provisioning in Australia, and are now proposing a new aged care system. And I think this can be an example from which we can learn to think about it for other countries. And finally, the case of the national care system in Argentina, a country in the global south, that is now being pushed. And I would like to highlight that in this experience, care is understood as a right, work, and a need. And I think it's a very interesting approach, and it's a feminist approach. The way as the national care system in Argentina is being thought, is being planned, has a really feminist approach. So I think there's a really interesting window of opportunity there. I will finish by saying that we will try to make clear in the study which our transformative horizon is. That has to do with reorganizing the social organization of care, in the idea of social care co-responsibilities, the redistribution of care, not only among men and women, but also between the care actors. But here we have a very clear position, understanding that the state should be a real leader of this transformation, the key role of the state as a main actor for this transformation, and the key role of public provisioning that should guarantee quality of care work at the center of this transformation. Also because when the quality of care work is a good quality, then the quality of care, of the care that is provided by this care work is also good. We really believe that this transformation is possible, and that is why we support this global call for rebuilding the social organization of care with the state and the public provisioning as the center. And as we say at Dawn, this call needs to be articulated with other fundamental systemic changes that we need to make this a better world where to live. Thank you.